So the topic tonight was to talk about how to manage recurrent acoustic neuromas. And recurrent acoustic neuromas are, hopefully something that not a lot of people need to deal with. But if you do need to deal with it, what are the ways to potentially manage it? And so we're going to talk about that tonight. Um, as When you start getting down into the nitty gritty about recurrence of acoustic neuromas, we really have to start looking at the data in fine detail, because you'll see with some of the data, it starts getting sparser and sparser. And so for a lot of the discussions tonight, I'm going to show you a lot of data tables, and I don't want anybody to get overwhelmed with these complex tables, so I will always just point out the key highlights and take-home messages out of each table. A lot of the material here on the slides were put together by Dr. Horry, who's one of the clinical instructors here in the Department of Neurosurgery, who collected pretty much all the data that you're going to see in this slide deck. So let's jump in and get going in this. For acoustic neuromas, just so everybody understands the anatomy, they are tumors of the vestibular nerve that runs in the inner ear. And so you're looking at the ear anatomy. This is what's called the external ear canal up to the eardrum. And then between the eardrum and the three small bones, this is the middle ear here. And the middle ear has a connection to the eustachian tube, which is why your ears pop when you're on an airplane or when you yawn. And then there's the component of the ear that's called the inner ear, and that's the area where the acoustic neuroma grows off of. A typical nerve looks somewhat like this, where you have the neuron shown in yellow. That's actual nerve that conducts the signals to the brain, and it's coated with this Schwann cell, this myelin sheath. And the Schwann cells are insulation, but they also allow the nerve to conduct signals more quickly than uninsulated nerves. But these Schwann cells, this bluish color material around the nerve, is what replicates when you get a vestibular schwannoma, or otherwise called an acoustic neuroma. So it's not the nerve itself that's like growing, it's this coating around the nerve that's actually growing. There's been a number of classification systems for acoustic neuromas. This is one of the most common ones. It's called the Coues classification, and it's neurosurgeons are not super bright people, so we just number things 1, 2, 3, and 4. And so you'll see here, number 1 is a small acoustic neuroma. 2 is a little bit bigger. It's starting to stick out into the prepontine CP angle space. And then grade 3 tumor is touching the cerebellum and the brainstem, and a grade 4 tumor is indenting the cerebellar and the brainstem. And you can see these are on the right side, the MRI equivalents. So a grade 1 tumor, a grade 2, 3 is just touching, and then a 4 here. So most of the time when you see your doctor, they're not going to bring up this Coues classification. It's like I said, it's mostly just a neurosurgical internal way to classify it. But your doctor will say you have a small one, or medium one, or a large one, and essentially their grade 1's a small and grade 4 is a large. So what is the actual treatment options the first time you show up with your tumor? Well, if you have a small tumor, like is shown in the top slide here, oftentimes your doctors may just say, let's just watch and get a scan in 6 months or a year. And essentially, I always like to tell my patients that each MRI scan is like a data point on a graph. And the more data points you have, the more you're able to figure out trend lines and growth patterns. But when you just have one MRI scan, that's your first MRI scan, you don't really know how long the tumor's been there. You don't know how fast it's growing. You don't know if it's going to be growing at all. So when they're small, we often say watch and get follow-up scans. Now, if the tumor does show some growth, that demonstrates that it is an active tumor. And by active, we mean it's getting bigger, it's going to start to cause problems, presumably. And so as the tumor shows growth, we start talking about treatment options. And as you are all aware, the two main options that we use for these tumors are radiosurgery and microsurgery. If you have a very large tumor that's really putting pressure on the brainstem, and the patients are either falling over or having facial pain or debilitating headaches, then you pretty much go with surgery, because that's the only way to get pressure out of the system. But if you have a small to medium-sized tumor and you're only having hearing related symptoms or tinnitus, and you're not having a lot of the more severe symptoms, then radiosurgery becomes a good option. And just right now at the present time, roughly, I would estimate about 75% of the patients that are diagnosed with acoustic neuromas in the US get radiosurgery, and about 25% get microsurgery. So from the surgical aspect, your doctor will talk about three possible surgical approaches. On the far left is what's called a middle fossa approach. We actually come in above the ear and we sneak under the brain and get to the tumor. This is good for small acoustic neuromas up to about 1 centimeter or 1.2 centimeters. It's not very good for tumors larger than that, just mainly because of the exposure. Picture B is what's called a translabyrinthine approach. There's a lot of bone drilling to get down to the tumor, but it often gives you a little bit straighter shot to the tumor from a visual angle. And then C is what's called a retrosigmoid approach, where you come in behind the ear. It's nowhere near as much drilling as a translab approach. And the retrosigmoid approach is a very familiar approach to neurosurgeons. So a lot of neurosurgeons prefer this type of approach. So that's how we get down to the tumors. So let's start looking at some of the data. This is a graph here that talks about how often, if you have surgery as your first treatment, how often will the tumor start growing back? And it really is a function of how much of the original tumor your surgeon is able to get out. You can see in the red line here, red line is your doctor got out at least 95% of the acoustic neuroma. There's only 1 to 5% of it left. And you see in red here, that's pretty good. If you go out 15 years, 95% of the patients still don't have any further growth, and only 5% showed growth. If you get out what's called a near total resection, where you get almost all of it, but there's still some left, then it's about a 15% recurrence rate. So red is get it all out, or 99% of it out, and green is you're getting out, let's say, 90% of it. And then blue is if you get what's called a subtotal resection, and that is where you're clearly not able to get the majority of the tumor out. So you're not at 95% resection, you're maybe at 60-70% resection, and then you had to stop for whatever reason. You can see that when you get out to about 10 years, 70% of the patients have shown regrowth. So this does show that, obviously, if you are able to get all the tumor out at the time of the first surgery, that lessens the chance of recurrence. But as you all are likely aware, the more the tumor you go after during the surgery, the greater the chance of some of the risk factors that we see, such as facial nerve weakness. This graph here shows the surgical results from the same series, looking at size of the tumor. So you got to remember, 1 is the smallest tumor and 4 is the largest tumor. And so if you looked at the patients that had a complete resection of their acoustic neuroma, which is about 284 patients or 75% of this series, you can see most of them are small to medium sized tumors. And as you get into the larger tumors, you see it becomes more difficult to get a complete resection. So when you're talking about the larger tumors, 40%, were able to get what's called a near total resection, maybe 90% resection, but a good 30% of the patients had what was called that subtotal resection. So this just goes to show you what seems to be empirically obvious, which is the smaller the tumor, the easier it is for the surgeon to get out. So what happens if you have surgery for your acoustic neuroma and the surgeon's not able to get it all out, and you got some left, and you have the radiation, stereotactic radiosurgery? What are the control rates? So this particular study looked at that, and we saw how in the previous slide, if you had only a subtotal resection, you had greater than 50% chance of the tumor starting to grow back within 5 years. And what we learned with this study here is that when you add the stereotactic radiosurgery to treat the portion of the tumor that remains after surgery, the chance of the tumor growing back goes from over 50% down to just 5 to 10%. So this shows that if the surgeon is not able to safely get all the tumor out, and there's a reasonable percentage there, let's say 20% of the tumor is left, it may be wise to consider upfront radiosurgery to treat that 20% remaining tumor so that it doesn't ever grow. And if you do that, you can see again a substantial improvement in the long-term control rates. So radiosurgery, I think some of you are familiar with this. It's a way to deliver high dose beams of radiation with high precision. So I like to think of these as laser beams that come in, and there's various different machines. On the left, there's a gamma knife system shown at the top, and then there's a CyberKnife system shown at the bottom. And over on the right side, you can see how we carefully outline the tumor on the scans. We also outline critical structures such as the cochlea, where the hearing nerves live, and then we plan our radiation accordingly. So if you just do radiosurgery, again, that's your only treatment that you've had for your tumor. You got diagnosed and you went with radiosurgery. What is the chance of recurrence? And again, it's a function of size. This one particular study looked at you see 167 patients, and the very small tumors, the ones that are less than a centimeter, had no growth. I mean, you had 100% chance of killing the tumor with radiation for small tumors. Now you can see as the tumor gets larger, you see the percentages here. The chance of controlling the tumor goes down. But even at the largest tumors, those greater than 3 centimeters, we still have a 91% chance of long-term control if you choose radiation as your first treatment, and a 9% chance of recurrence. Okay, so now we see what the rates are for recurrence after radiation, and we see what the rates are after recurrence after surgery. So now we're going to start talking about what are the options in that situation if you do have recurrence. Let's get that. We'll talk a little bit about this is a phenomenon that sometimes scares patients if they don't know what to expect, and this is called pseudoprogression or swelling after radiation. So if you don't understand this principle, it can falsely make you believe that the tumor is actually starting to grow again. And since we're talking about recurrent acoustic neuromas in this presentation, we also have to talk about pseudoprogression. So this is an example of pseudoprogression. A is on the left side. That's the size of the treatment, the tumor on the day of treatment. Then at B, you can see that's the size 2.5 years after treatment. So you can see there's some nice shrinkage. Everybody is happy that you were getting a good result after the radiosurgery. Then when we get to C, this is 3.5 years after treatment. So B is 2.5 years after treatment, and C is 3.5 years of treatment. It looks like things are growing again. You know, when you look at the picture and C, the tumor looks bigger than B. So is it growing again? And it turns out that, again, if you wait further, D is at like 6.5 years. It came back down. So pseudoprogression is temporary swelling in the tumor as the tumor dies and undergoes its inflammatory process. And if you don't understand this issue, you can falsely think the tumor is, growing again. And then if you got to see and you thought the tumor was growing again, maybe you would take that patient to the operating room or do another course of radiation. And in reality, you didn't need to do that. So understanding pseudoprogression is really important. And in the challenge is that pseudoprogression means the tumor looks bigger. How do we tell that difference between pseudoprogression and a tumor that's actually really growing? What's the best mechanism by which we can separate it out? And the answer is that early on, it can be almost impossible to separate out pseudoprogression from true tumor recurrence, because in both cases, in the short run, the tumor size increases. In the longer run, the pseudoprogression will cease and the tumor will shrink again, whereas true tumor progression will continue to grow. So in the short run, no difference. Both pseudoprogression and real tumor growth are showing an increase in the size of the mass. But then as you get further out, you start getting a divergence where pseudoprogression shrinks again and true tumor progression will continue to enlarge. Now, what do we know about pseudoprogression? There is thought to be two time windows when you can see some pseudoprogression. And understanding these two time windows is important. A lot of doctors don't understand the second time window called late pseudoprogression. I'll talk about that and why. But looking at the left side, we see that the first chance of what we call tumor swelling occurs about a year after you do the treatment. The tumors take about 2 years to die, theoretically. And during the first year, there's a lot of inflammatory processes going on. The dying tumor releases inflammatory molecules that just create inflammation. And the inflammation is the mechanism by which the tumor dies, but the inflammation is also the mechanism by which you get some temporary swelling in the tumor. And we see this inflammation, with any other types of injury. If you sprain your ankle, it gets swollen. If you get a bee sting, you get some swelling. When we call this swelling that occurs in the acoustic neuroma after radiation, as I said, typically occurs about 12 months after that actually shrinks, becomes smaller than it was when you started. Now, typically at about the 5-year mark after radiation, there is another chance of seeing some tumor swelling. And this is much less understood because it's thought that the tumor dies in the first 2 to 3 years after the radiation. So what's going on at year 5 that it creates this pseudoprogression or tumor swelling? The mechanism is thought to be different than the early tumor swelling, which is related to inflammation. The late swelling that occurs at the 5-year mark is thought to be related to some vascular events, some changes in the blood vessel phenomenon that occurs in the tumors. And this is a late effect of radiation. It's late because it doesn't occur right away. We don't see it till 5 years. But this is something that even a lot of neurosurgeons don't understand and know about. And so at the 5-year mark, they're telling the patient, your tumor's growing, you need another treatment. And in reality, it could be just this is late treatment effect there. So let's talk about first comparing the radiation with surgery, because if you're choosing a treatment for your acoustic neuroma, either the first time or if you're choosing it because your tumor recurred, it's important to know, kind of what you're getting into. The main advantage of radiosurgery compared to surgery is that there is less risk to the facial nerve, and it's thought that in some patients there can be a higher chance of hearing preservation. However, the radiosurgery does not physically remove the tumor. So if you're having symptoms related to just the sheer size of the tumor or the pressure the tumor is putting on the surrounding structures, things like headaches or falling over because of balance, radiosurgery is really not going to fix that problem. Okay, so now you're in that situation, you're in that 10% or so, or 5% or so, where your tumor really appears to be coming back, and it's not the swelling, it's not pseudoprogression. So what are the management options? And you can see in this slide here that if you have surgery and your tumor comes back, you have the choice of a second surgery, or you can go with radiation. And conversely, if you've had radiation and your tumor grows back, you can go to a second course of radiation, or you can go to surgery. And we'll talk a little bit about these combinations. And as I said, the data becomes a little bit more sparse as we get deeper into this. So I'll show you the data, and we can talk about what it is. But you're not going to see as large hundreds and hundreds of patients in each of these categories. Okay, so this particular paper looked at all what's called a meta-analysis of literature. So it took a aggregate of all the data in the medical literature about doing a second surgery after you've had a first surgery for your acoustic neuroma. And what we saw with the second surgery is that at least half the patients that reported the results was that with the second surgery, you can see the gross total resection was, almost 80% of the patients that the data that actually reported how much of the tumor was resected. And you might say, well, that seems high. That's even higher than maybe the first time you did the surgery. Why did the surgeons just get better at doing the surgery, or what's going on here? It turns out that when you're talking about a second surgery, the kind of the goals shift a little bit, because with the first surgery, we know there's a high chance that there'll be some long-term control if you do a reasonable job with the resection. With the second surgery, we are worried about, is this tumor becoming more aggressive? Is it growing faster than a typical acoustic neuroma? Is there something about this tumor that's going to cause problems and require a third or fourth surgery? And so with the second surgery, the surgeons are really trying to get it all out, because they don't want to even have a little bit remnant left that can get going again, because you've already, something about your tumor has declared itself as being more aggressive. The challenge here with being more aggressive with the surgery is that the side effects go up. So here's the results of the facial nerve. So on the left, you see after a first surgery, this was a total about 200 patients. About 25%, 20 to 25% had some severe facial nerve dysfunction, but slightly more than half pretty much had normal function. But after the second surgery, you can see that the chance of coming out with normal facial nerve is lower, and the chance of coming out with either a moderate or severe facial nerve dysfunction goes higher. And that's, again, it's because the surgeon is now trying to make sure that they get it all out or most of it out, because the last thing they want is to be setting you up for a third surgery. So again, risks go high, go up with a second operation for your acoustic neuroma. So let's talk about, you had surgery first, your tumor grew back, 5 or 10 years later, and now we're going to do radiosurgery. What's the data show? So there are a number of papers that look at this, and essentially, if you have radiosurgery after you've had a surgical resection, you can see the results shown here. Pretty good data long term, meaning that you had a recurrence after your surgery, but now that you've had radiation, 95% of the patients had good long-term control with that second treatment. And the chance of it growing after that second treatment of radiosurgery after surgery is only 5% at the 10-year mark. So it seems like radiosurgery can be a very good salvage treatment for growth after surgery. But let's flip the table a little bit. Let's say you've had radiosurgery as your first treatment, and you have a tumor that's demonstrating growth. It's not that temporary swelling or pseudoprogression. And now you're looking at your options. You have the surgery or radiosurgery option, but let's say you talk about surgery. Where are we at? So this is a paper that looked at surgery following radiosurgery. And a couple of things you can see from this data here is that it's, about 2/3 of the patients have less than a complete resection. And that may be because the radiation created some post-radiation effects, some scar tissue, some variation in the anatomy that made it more difficult to resect. But even in this patient population, you can see that the long-term control rate is still pretty good. If you have surgery after radiosurgery for your acoustic neuroma, you still had a pretty good long-term control rate, meaning 90% at 5 years of the patients still had control of their tumor. This is another paper that kind of looked at the same topic. Again, if you have to do surgery after radiation because of some potential scar tissue, they can make it so that you're not able to get a good complete resection. In this case, only 50% of the patients had a complete resection. You can see 22% of the patients have some facial nerve issues, and there was about a 20% complication rate. So a surgery, whether you do it after a first surgery or whether you do it after radiation, there are changes in the anatomic environment as a result of the first treatment, whether it's surgery or radiation, that can make a second surgery more challenging to do. We see that the data bears that out. And then finally, we're going to talk about, you had radiosurgery. The tumor was controlled, let's say, for a number of years, but now it's growing back, but still within the size criteria of radiation. And now you opt for a second course of radiosurgery. It turns out that you still get pretty decent results. You can see the long-term control rate after the second course of radiation was 95%. So only 5% of patients failed the second course of radiation. But we're seeing a little bit higher sets of complications. The impact on the trigeminal nerve and facial nerve and ability to maintain hearing is lower than it would be for the first course of radiation. Let's see. Let's talk about this thing here. So this compares all 4 of the different combinations, and again, you can see that the data is pretty small numbers here, both in terms of actual numbers and percentages. I do think if you look at things like the facial nerve function here, those that had radiation after surgery still had a pretty high chance of facial nerve function, 84% chance. But if you've had two surgeries in a row, you know, the chance of a normal facial nerve function is pretty low. Converse, and again, in a similar format, if we look at the next two columns here, if you have two sets of radiation in a row, the chance of preserving your facial nerve is still 100%, although the number is small, there are only 7 here. Whereas if you've had radiosurgery and then you go with surgery, the chance of injuring the facial nerve is about 30%. So I think the big take-home message here is, even though the numbers are relatively small here, specifically to the facial nerve function, it appears that even 2 courses of radiation are fairly safe for that. So kind of to conclude, the take-home message is that tumor recurrence rates after treatment depend on a number of factors, including the size of the tumor, and if you do surgery, how much of the tumor you're able to get out. We know that larger tumors just have a higher chance of recurrence. And if you have a resection that they're not able to get out a lot of the tumor or most of the tumor, you're going to have a higher chance of recurrence than somebody that's had a more complete resection. Obviously, any previous treatment can make a second treatment more difficult. So if you've had one surgery and you do a second surgery, at the time of the second surgery, you may encounter scar tissue from the first surgery. If you have radiation and then surgery, same principle. We also see if you've had surgery first, sometimes it's harder to do the radiosurgery because your ability to contour and target the remaining tumor can be somewhat compromised by scar tissue and other inflammation that we see after surgery. But both surgery and radiosurgery, and using good judgment and at experienced centers, can still show overall decent outcome rates for treatment with recurrent acoustic neuromas.